you'll hopefully find to be an interesting and engaging topic. So by posing that question, and really for both debates, what we're really wanting to provoke is thought and careful consideration of both sides of an argument. So you won't know which side you'll be arguing until after the final lecture. So it's important to consider both sides as you go through the lecture program. And what we really want to encourage is being able to make an argument for a side which you might not personally believe in or think is necessarily right. And that's an important life skill, and you'll almost certainly have to do that at some point. It also allows you to consider where your opponent is coming from and see the case or the argument from their side, and that helps build consensus, or it helps you reach some form of compromise. So when making your arguments either for or against the proposition, you're going to need to back it up by reference to primary and secondary sources. To assist you with that task, we've got a series of lectures from specialists in particular fields and on what we're going to call the core subjects relating to the topic. So that's going to be on medicine and health, which is the topic of tonight's lecture, the environment, the maths, or slightly the economy, and general science and production. So we're going to cover all those particular topics, and that's particularly important because each topic will be covered by one speaker in the debate itself, and you'll be able to see the details of each speaker on the Mock Court website along with the timetable. In addition to the lectures, we also expect that you'll be carrying out your own research into the topics to assist with strengthening your arguments and putting forward the best case that you can for whichever side you happen to be on. And when conducting the debate, each speaker will voice their argument for or against the topic and focusing on their assigned core subject area. From the last lecture, you'll have where you'll be told which side you'll be presenting on. You'll have 2 weeks to prepare with your team for the final debate. And the debate will be live using this vCourt system. And we'll be live streaming the debates also to YouTube, which means that your parents, family, and friends can all watch if they want to. And the first lecture today is going to be from Dr. Marshall Garrett, and he'll be looking at the medical and health impacts of plastic use. During the lectures, we'd ask that you make sure that you keep your webcams turned off until the Q&A session at the end, when you can turn it on if you're asking a question. I'm not sure if that feature is working today. So I really hope that you enjoy what we've put together, or what's been put together for you, and that you really start to engage with this topic in a lot more depth than you would necessarily be able to do in a traditional debate. So before the lecture starts proper, I'm going to pass you over to Dorota Zabłodowska, who's a Polish judge and has been involved in setting up the debate program and coordinating the speakers and obtaining them to come and speak to you throughout the program. So I wish you all the best of luck, and I hope you really enjoy the project.
Thank you very much, Louis. Thank you for this thorough introduction to our project. I would like to give you all, first of all, welcome, and let me say how extremely happy I am to see so many people joining in this particularly difficult time for all of us, all of Europe. Somehow, thanks to projects like this, we all feel more together, even though we are separated by borders that ceased to exist before the pandemic. Coming back to the project, it has come from an idea that there is so much information surrounding us, bombarding us, that we don't know what to think about it. And we, Gerald, Anne, Catherine, and I thought that it would be a good idea to practice thinking, practice critical thinking, and checking up the facts, because when you get to know a piece of information, the first question you should ask yourself is, where does it come from? Is it credible? And why? I have been a criminal judge for almost 20 years now, and being a practitioner in the courtroom, I have learned how important it is to check the evidence, because very often people come to the court and they say, well, I know that. I know he did it. I know he's this kind of person. And my primary question to every such a witness is, how do you know that? What is your background? And when you ask this question, it very often happens that the person says, well, it's a gossip I heard. I don't remember who told me that. And in that way, I can separate the valuable evidence, the credible evidence from the evidence that is not really evidence, it's just gossip. So, excuse me, I am sorry. The aim of this project is not to prove who is right. It's the aim of this project is to find out and to teach you how to gather evidence, how to check up the facts, how to evaluate whether what you're hearing or reading is credible or not. And we very much think that the debate program will be a valuable addition to your education in that aspect. It is not important what you think in the context of our topics, because, well, some people, of course, think that plastics are bad, some people don't. And it probably is so that we agree on many subjects, and you have to be the devil's advocate and try to find arguments for something that you don't really believe in. And that's a huge challenge that we are putting in front of you. Moreover, I think I can reveal the secret that some of our panelists also have been given this task to argue something that they don't really believe in. So we'll check not only how you can manage, but also how our speakers will manage to do the lectures in a convincing way. So my advice to you is, whatever you want to say in a debate, you've got to have, you have to support it with evidence, with facts, with arguments that are grounded by scientific sources or legal sources or whatever sources you can find, not only Google. So having said that, I am wishing you best of luck, and I'm passing the floor to our speaker, Dr. Marshall Garrett. Thank you.
Good afternoon, ladies and gentlemen. I'm not sure if you can see me on video link. I don't think that is actually active here. But just like Judge Dorothea, I'm absolutely amazed by the number of you who are online this afternoon, and that, frankly, is very flattering. Thank you so much for your time. I loved the way that Judge Dorothea said that some of your expert speakers may be arguing against their normal position. I'd better introduce the fact that I'm a medical legal specialist, so I spend all my time weighing up evidence of pros and cons in medicine, whether treatment's good, whether treatment's bad, whether somebody's done something well, whether they could have done better. This evening, I'm going to approach this in a slightly different way to that you might expect. My other job is that I'm one of the senior lecturers at Glasgow University, educating medical students and junior doctors. And I have found that the best thing and the best way to look at a particular subject is to actually understand what the issues are. And more often, is there a historical precedent here? Have things changed from where they started? Have new pieces of information come along? Has science moved forward? I would encourage you to think about that through the talk, because all of you have been brought up in a world where plastic is commonplace. I'm sufficiently old to remember when many items weren't necessarily made of plastic. And the older you are, the more you can relate to a world where various items were made of a different substance, but plastic has become ubiquitous because it is so useful. But it's not all good. Anyway, it's worth understanding what you're talking about. Why are plastics such a problem? Why are they so widely used if that they pose a danger to humankind or indeed our world ecosystem? Now, here's a thought for you. I just said that plastics have been in wide use for the last 60 years. That's true globally. But would it amaze you if I told you that the first plastics were around 3,000 years ago? Surely not, you say. Chemistry says this is a man-made process. We link various monomers into a long-chain polymer. That didn't happen. Well, let me educate you. For those of you who don't recognize this scene, this is an Olmec ball game. This was played back in the Olmec and Mayan civilizations, and the whole idea was that there were two teams in opposition, and they had to get that ball through that hole. Obviously, there is another ball and another hole on the opposite side, but that ball that I'm indicating there, that was made of naturally occurring latex, and latex is the earliest known plastic. Essentially, it's a long-chain hydrocarbon polymer that's produced naturally in plants. It's quite heavy, it's quite dense, but it bounced. And that was the single most interesting property to the Olmecs. They needed a ball that would bounce off these angled walls and provide exciting play. They could have played it with a rock, but it wouldn't have bounced, it wouldn't have moved eccentrically. So the very physical nature of that early plastic was what attracted them to it. And that was 3,000 years ago. Incidentally, those balls are so incredibly heavy and incredibly dense that they weigh in excess of 5 kilograms. And there are actually Olmec skeletons and mummies that have been unearthed with fractured femurs, which were presumed in otherwise young males to have been fractures caused by the dense latex ball. Now, I'm going to move on to that slide for you, but I'm going to bore you all by introducing you to a little bit of chemistry. I hated organic chemistry as a medical student. It was just putting molecules together, making a complex molecule, how an organ in a body broke that down into something separate. And it wasn't day-to-day interesting stuff. It was kind of complex chemistry, and they examined you on it, and they didn't give you good marks if you weren't very good at it. But actually, chemistry matters. And I make no apologies for giving you a very quick overview of what plastics actually are. Now, you all know, I hope, that plastics are essentially hydrocarbon-based. Hydrocarbons equals crude oil, essentially, and natural gas. Plastics aren't derived directly from crude oil and natural gas. They have to go through a process. And that process is known as cracking, where you take the long chain of hydrogen and carbon atoms that makes a long chain hydrocarbon, and you break it up into smaller and smaller building blocks. In this case, two principal ones: ethane, which is derived from hydrocarbon fuel oil, and propane, that's derived from natural gas. Once those have been cracked in a facility, you can employ a chemical process linking those sequentially into a chain. And that gives you a long chain flexible polymer. So if you get ethane and you have multiples, poly, you get polyethane, known as polyethylene. If you do the same with propane and you join those, we have polypropylene. All of you, I'm sure, will recognize polypropylene as a basic blue twisted plastic rope, and polyethylene you can make into just about anything. But once you have those basic long chain hydrocarbons that are flexible, you then add additional additives which modify the properties of the plastic. And the most typically added are bisphenol A, I'm not going to ask you to understand the chemical or molecular structure of that, because I don't either. And phthalates. Now, those make the plastic either more heat resistant, it can change the color of the plastic, it can improve its moldability, its very plasticity, which is where the name plastic derives from. But there's a problem with those additives. They're extremely toxic. And those particular additives, phthalates and bisphenol A, have major effects on multiple organs. The brain primarily, not immediately, but over a long period of time, and cumulative exposure to bisphenol has been shown to cause neurodegradation or brain damage. Phthalates tend to be more at the kidney and the liver level, but they can affect vision, they can affect blood supply to the eye and the retina, and consequently, the more you're exposed to those particular drugs, the more risk we have. We call it phthalate or bisphenol load, and that load comes directly from exposure to plastics. Now, a plastic sheet or a plastic bag put over your head and held tightly over your throat is going to kill you very quickly, because effectively it's impermeable to air. Air can't pass through. But if you just open the bottom of it, air goes in, you can breathe perfectly fine again. So what's the problem with plastics? Plastics do not break down easily. To say plastics are indestructible is incorrect. Plastics will slowly break down, but they require exposure to light, and particularly UV light. They require exposure to chemicals. They need to be able to oxidize, and they also need temperature to increase the rapidity of those catalytic reactions. Now, if you have a look at this list here, a cigarette butt, 10 years to break down. Plastic grocery bag in a marine environment, so in salt water, not at high temperature, but average around the world, ocean temperature is about 24 degrees. Styrofoam cup, 50 years. Plastic cup, 400 years. Disposable nappies, 450. And I'm just drinking out of a single-use plastic bottle. It's going to take 450 years to break down. Fishing line. It's dense, made of polypropylene normally, extruded into a single monofilament, 600 years to break down. That, however, is degradation through a chemical process. What actually happens more and more with plastics is exactly the same process as erosion of a rock. You can take a solid piece of granite and you would think it would sit there for thousands of years. Yes, it will. But over thousands and then into millions of years, the effects of repeated heating and cooling, the effects of glaciation, the effects of friction will break that down into smaller and smaller and smaller pieces. Effectively, you go from rock to sand. Exactly the same thing happens with plastics. Plastics break down into smaller and smaller and smaller small residuals, often at a microscopic level. And they're known, incidentally, as MOOP, M-O-O-P, microorganic plastic. And microorganic plastic has the capability to enter the food chain. It is ingested. And we have to look at the food chain to totally understand exactly what happens. But let's work out how your plastics get into the food chain and start causing disease and start causing problems. This, incidentally, I thought was worth showing you. That looks like landfill, but it is not. That is a commercial plastics breakdown composting facility. And you'll notice there in the background that there appears to be smoke. That isn't smoke, that's steam. There is a whole network of pipes underlying the entire facility, and those pipes are carrying steam to increase temperature. Temperature being one of the integral requirements for plastics decomposition. Then, if you add in certain biological organisms, waxworms, mealworms, they have the capability of producing enzymes that can break down plastics And ultimately, the breakdown of plastics is down to carbon dioxide and water. But they need heat, they need exposure to light, as you can see here. This is well lit, although it's not in a particularly sunny environment. But would you believe that these huge furrows of plastics, all varieties of plastics, polyethylenes, polypropylenes, these can be broken down, instead of in 400 years, in between 39 and 60 days. But this requires manpower, this requires complex chemistry, it requires machinery, it requires heat, and it requires an educated population. This sort of facility is only really available in what would be known as first world countries, whereas developing countries and developing economies cannot yet afford to indulge to this level in composition. Now, plastics are going to get from your home into the environment, usually through sewage or simply through fly tipping. And then they get into rivers, and as we all know, rivers ultimately run to the sea. And this shows the most polluted rivers in the world in terms of metric tons of plastic debris that are washed down them annually. Unfortunately, the top 10 rivers produce 90% of the world's plastic waste. And if you look at the list there, these are all coming from Asia, Africa, with the exception of the Amazon. But given the sheer size of the Amazon compared to some of these other rivers, the Amazon is comparatively lightly polluted, much of it because of its geography, where it's running through low population density areas. But there you are. I'm afraid China is very much at the top of that list, despite an aggressive and developing economy. We'll come back to whether some of the biggest economies in the world do their best. Oops, my apologies. I managed to go 2 slides forward instead of just 1. There we go. So, regrettably, that is downtown city centre in India. You can see that the river surface here is virtually covered in plastic debris. Now, this hasn't reached the ocean yet, but if you look carefully, you can see that some of these are getting broken down. There's not much decomposition, but we've got the grinding together. We've got the slow reduction of the intact plastic element into its small microorganic plastic. Let's see if I can get the next slide. It seems comparatively unhappy to do it. Now, for those of you who don't know what this is part of the Great Pacific Garbage Patch. This is the eastern side of the Great Pacific Garbage Patch off the coast of the United States. And this is formed in an ocean gyre where all these pieces of plastic debris are accumulated on the surface of the ocean. And essentially there is a spinning current there that keeps them static. You might be absolutely amazed to know that the Great Pacific Garbage Patch is now 5 times the size of France, or 4 times the size of California. Most of you probably won't have seen an image of it because it's out of sight, out of mind, floating on the ocean's surface. But there you are. There we have our Californian garbage patch. This is the subtropical convergence zone where all that garbage that was coming from Asia is coming in. We've got stuff coming from the US, who are quite heavy polluters themselves. And effectively, we've got 2 nice gyres starting up there. This one is slightly denser. This one is a little less dense, but unfortunately, the density of the Western garbage patch is increasing because of the plastic load coming in from Asia. So that gives you a bit of an idea about what's going on here. And because all of the plastic structures in these two garbage patches are effectively being jiggled up and down by the waves and rubbing against each other, we're getting erosion. We're getting microplastics being produced and going into the sea and disseminated widely across the oceans. Come along slide. It would be really nice if the slides would change when they need to. Oh. Let me just go to slide 9. So that is a zooplankton. And you can see that these zooplankton have got lots of little green fluorescing dots around them. Those are single entities of microorganic plastic. But if you have a look there, that is the zooplankton's gastrointestinal tract, and that's now full of microorganic plastic and breakdown products such as bisphenol and phthaleins. And that microplankton is probably going to be eaten by a slightly bigger fish, which is still going to be very small. Then there's going to be a slightly bigger fish than that, eats that fish, and so on, until we get to large commercial fish or other sea animals that enter the human food chain. And we are all of us, contaminated already by microorganic plastics and their breakdown products. Possibly, it might leave me brain damage sooner than you guys. Now, I thought I would let you have a little look at this. Everybody says, well, plastics are dreadful for the environment. We shouldn't be using them. We should find alternatives. The problem with that is society has moved to the stage where plastics are effectively indispensable. Ignore that this is a plant bottle. I'll come back to that. What's the benefit of that Coca-Cola bottle in your day-to-day backpack? That's a rhetorical question. It's because if you drop your backpack, it's not going to smash. It's not going to cover all your important work materials with sticky Coca-Cola. It's not going to short circuit your laptop. So essentially, those bottles are not what we call frangible. Frangible is fragile, like glass. You smack it on something hard, it shatters. It produces sharp edges. So therefore, you have the inconvenience of getting your notes and your computer damaged. You lose your Coca-Cola, and there are sharp edges that are potential injuries. So surely, a plastic bottle that doesn't smash is an advance. Yes, it is. And that's why plastic, usability and convenience are the watchwords. If it's usable, it's convenient, it's clear, that's great. The reason I'm showing you this is because I think Coca-Cola, and let's all be fair, Coca-Cola is a big company. It's like big pharma. It's like big oil. It's big Coca-Cola because it's such a massive world behemoth. But look at that. It's a plant bottle. It's made from biodegradable plastic. Oh, what's that, I hear you say? Well, plastics can also be made from monomers derived from foodstuffs, from corn, from sugarcane, from waste food products. You then put those together as your monomer, and you can add additives for plasticity, translucency, etc. And you can get a very, very acceptable bottle, but you just need to put a thin plastic label round and a thin plastic cap on, and wow, you've got a fantastic eco-friendly bottle. No, you haven't. Only 30% of that plant bottle is made from plants. 100% recyclable bottle. Well, yeah, plastic's recyclable if you collect it, you grind it, you melt it, you use it to reform plastic bottles again. But it's a circular process. You only use a Coca-Cola bottle once and then you normally throw it in the bin, apart from some people that will refill it with water and it's convenient to carry. That, I would suggest, ladies and gentlemen, is really a bit duplicitous. Yes, 30% is made of biodegradable plastic that will degrade more quickly, but the rest of it is still made from hydrocarbon-based plastic that we still need to use. So big companies aren't making much progress fast. So I've spent 20 minutes giving you an introduction. You were all wanting to know about plastics in medicine, and that's what I'm here to try and teach you about. This is a very famous image which derives from the early 1800s. And this essentially is what medicine was like back in those days. Look at these individuals. They've got butcher's aprons on. They've got clothes that are their normal day-to-day clothes. They've bothered to roll up their sleeves. Doesn't really look as though anybody's washed their hands. They've got the junior boy holding the leg that's being amputated. And we've got a nice rough wooden handled bone saw there that you can't see very well. And we've got obviously the chief guy over here who's wearing his frock coat. And we've got the poor patient, needless to say, who looks nigh unto death. Back in the day, and when I say back in the day, I mean up until the late 1800s, 1867 to be precise, medicine really was very basic. There were no antibiotics, there were very few effective drugs, and there certainly wasn't any anesthesia. So surgery was brutal and bloody, and nobody had ever heard of asepsis. Asepsis is the idea that you can transfer infective organisms from another surface, a person, to the individual's tissues, either when you're performing surgery or even unconsciously, and that transfer of infective organisms is what causes worsening disease. The classic example was prior to 1870. If you had a compound fracture, which I'm sure some of my audience will have had, where you break a bone and the bone's poking through the skin, the automatic treatment was not an attempt to restore anatomical integrity to the leg. You simply amputated the leg because without doubt it was going to become infected and an individual was going to get gangrene. That started to change, and that changed, as I said, in 1867, thanks to a man of whom we here in Glasgow are immensely proud. He was called Joseph Lister, and Lister actually came from England to Glasgow and was a trainee surgeon, where he began to have a suspicion that it would be much easier to diminish potential infections by a rigorous regime of hygiene, washing the hands, not wearing an old filthy butcher's apron. And incidentally, before the idea of asepsis came along, the mark of a successful surgeon was to have the most blood encrusted and pus encrusted clothing, because it showed you were a busy surgeon. The more filthy your working clothes, the more eminent you were. What Lister proved, however, was that if you maintained good hygiene using sterile or at least clean dressings and drapes around surgery, infusing the surgical area with carbolic acid, which was a strong and very astringent antiseptic, you could minimize the number of infections that you would see. Up until Lister's day, there was a 4 in 10 chance that you would die of an amputation or equivalent surgery on the table, either from blood loss or subsequent infection. And in many hospitals in England, you had to pay for your own funeral costs up front as part of the cost of your treatment. Lister changed that, as I said. And if I can get this slide to go again, sorry, I'll just do it by hand. Oops, I'm sorry, wrong one. Ooh, come along, slides. There we are. This is a depiction of Lister with his assistant, and this is a pump spray of carbolic acid solution. You'll notice the difference. We have clean uniforms being worn here, certainly a clean apron. We have clean if not sterile, drapes around the surgical area, which is obviously going to be in the central chest. I would point out that as anaesthesia hasn't sufficiently advanced, somebody doing a midline sternotomy incision, which is normally only used for going for the heart, it would be pretty brave of anyone to be doing that. But you get the idea. The next thing that made Lister supremely famous, and the reason that his opinions, forgive me if I want to try and get the next slide, I'm having fun here. Hopefully we'll get it in just a minute. The reason Lister became so famous was that he was actually called to Queen Victoria at Balmoral Castle. Excellent, that's what we need. Because she had an abscess in her armpit. Now, if in the late 1800s you were wealthy and rich and titled, you had a much better chance of survival because the eminent surgeons came to you rather than you having to go to them in their hospital where you would get fairly basic treatment. Lister, when he lanced the collection of pus in Queen Victoria's armpit, employed full aseptic technique. All the drapes were boiled extensively. He treated the armpit with carbolic and linseed oil, and then he performed using sterilized surgical instruments. I understand that the suture material used to close the resulting wound were also sterilized, and Queen Victoria made a marvelous recovery. Her pain was relieved, and of course Lister became possibly the most eminent individual in medicine worldwide. And therefore, because of his eminence and the weight of his opinion, if he stated that asepsis was the way ahead, the rest of medicine and particularly surgery followed. That's why Lister is known as the father of modern surgery. So where does that bring us to medicine and plastics? Well, we've had a sea change. We've had a change from operating in day-to-day clothes, not caring about hygiene, to having hygiene and an aseptic technique as part of even minor surgical procedures. Taking blood, for instance, you've all had it done. You use methylated spirits to swab and disinfect the area. You then insert a sterile hypodermic needle attached to a sterile syringe to draw blood. Surgery is the same. We drape with sterilized materials. We operate with sterilized instruments. So now we need to start looking at what changed beyond the aseptic technique and carbolic acid. We don't still use that. From the time of Lister in 1870 up to, let's say for convenience sake, 1960, which would be about the right time to take, there were a lot of advances. There were a lot of advances in antiseptics. There were a lot of advances in sterilization techniques. It became known that autoclaves using steam and pressure, using a variety of different solutions such as peroxide and ethylene oxide, were extremely effective antiseptics and antivirals. They were antibacterial, antiviral, antiseptic, antisepsis. Those were very good once you basically cleaned your surgical instruments or your surgical implements. But there were a lot more things that could be done. Even when I qualified in 1983, we were still wearing surgical blues that were 100% cotton, and they were great. They were like a nice 100% cotton Levi's t-shirt. They were comfortable to wear, they were cool. But if you got a blood splash on them, when you took them off, there was blood left on your skin underneath. So they were not a fluid barrier. They did not prevent transmission of fluid from the surgical field or from the procedure field to making contact with an individual's skin. And as I'm sure all of you are aware, particularly over the last year with COVID-19, fluid transfer, particularly bodily fluid transfer, is a carrier medium for bacteria and for viruses, and indeed for other small infective organisms, which are, if you like, bits of a virus known as prions. So that is why there had to be a change. And we started seeing differences in the operative blues or greens that we had to wear. They became hotter to wear for a start, and I was aware of discomfort and sweating within them. Now, it's commonplace to sweat in theatre. We have very, very bright lights. The theatres are specifically kept warm for patient comfort because they're naked on an operating table. And so surgeons do sweat, there's no question about it. But I was aware I was sweating more. And I suddenly realized that my blues were sticking to my back. My armpits were getting sweaty. I know it sounds disgusting, but they were. Then I started looking at the labels on the blues, and these were polycotton. Now, I'm sure some of you would never wear polycotton if you could possibly avoid it. And I certainly don't wear polycotton because I don't have to. I can choose. I have the choice to choose to wear cotton, which I wear because it is cool. But polycotton can be used to weave a much, much tighter, denser fabric, which minimizes fluid transfer. And also polycotton, and polycotton, by the way, stands for polyethylene or polypropylene plus cotton blend. It takes a waterproof barrier membrane. Either you can sew the membrane between two sheets of polycotton tufting, or you can actually spray it onto the garment to start off with. And that is now the norm. And what we found is it actually diminishes comfort in the theatre setting, but it is much, much more effective at minimizing potential transmission because we all have billions of bacteria on our skin. We're looking at transfer from a sweating back or a sweating chest through the greens, then going into the air, effectively becoming an aerosol and contaminating our surgical field. Hence the multiple layers, the surgical gowns on top, multiple layer barrier. And nearly all of those garments are either single use or limited multi-use. Limited multi-use means they're cleaned and sterilized 4 or perhaps 5 times and then thrown away. And the reason that they're thrown away at that point, before you've even broken in a nice cotton t-shirt, is because there is a perceived risk of infection. Whether there's actually any risk of infection is debatable, provided good sterilization technique, gamma ray irradiation, autoclaving, which can be poor because it breaks down some of our plastic because of the high temperature and pressures involved. But you can also do gas plasma, which is effectively using a peroxide solution at low temperature, which is very good as a bactericide and virucide as well. So let's go back to plastic. Why is that slide there? That slide's there to show you a very basic capability of plastic. A plastic is plastic, meaning it has plasticity. It can be bent and it's moldable. There you go. Look at this. There's a nice round tablet. Ooh, there's a blister dome. There's your typical capsule. There are different sizes and shapes, and all of these can be very, very easily produced in a template. So there's no reason whatsoever that you can't use plastic to be a perfect drug transport medium. It's incredibly important. These are see-through because you can make plastic translucent depending on the additives and the polymers that you put in the manufacturing process. At a glance, you can see, is this the right drug? I would sit there and think to myself, what do we got here? White tablet. Oh, could be paracetamol. Actually looks like paracetamol because normally there's that groove put through them. I look at these and I'm thinking, oh, green and yellow. Yeah, that's pretty likely to be a generic amoxicillin. And various things like that. It allows doctors, nurses, patients to identify their medication straight away. It also is airtight. It can be stored for a long period of time without taking up too much room. And effectively, it is the ideal material. It's not frangible. It doesn't break when you drop your pillbox. So drug storage, drug movement, excellent if you can use it in that way. How about we want to have a nice see-through plastic sheet? No problem. You can make that effectively. If you get a burn and you need to go to hospital, you haven't been there, what is the single best barrier to put on that? Cling film. cling film is a clear plastic polymer. The reason you put it on a burn is it minimizes evaporation from the base of the burn that's been exposed under the damaged skin, and it's that evaporation that tends to cause the severe pain with burns. So by all means, cover it with cling film. Even better, put a barrier cream of zinc oxide. Baby bum cream. When babies have irritated backsides, we use a zinc oxide paste, and that's a very good barrier cream. Putting on top of that cling film, it's a great dressing. We can't do much better apart from stick it down. Obviously, we take it down when you're in hospital, but then we get to work. How about a tube? You want a clear tube? I want to be able to see what's coming from my intravenous bag through the tube and into that individual's vein. I want to be looking at that and thinking, okay, I've got saline solution. I've got blood. I've got no gas bubbles. Because remember, medicine, one of the basic tenets of treatment is do no harm. But if I let 10 milliliters of air through my intravenous line directly into your vein, I'm probably going to cause a cardiac arrest as that bubble goes through into your heart, where effectively it becomes a gas that is compressible within the heart chamber instead of a fluid that is not compressible and is pushed around your circulatory system. It's easy to make with plastic. Plastics are moldable. They can be injection molded, they can be extruded, they can be 3D printed to make virtually whatever you want. That's why plastic is extremely useful. Let's see if we can get another slide. There you go, topical. So here's one of my co-workers, and she is wearing a face shield, polycarbonate. She's wearing blue nitrile gloves, nitrile, another hydrocarbon base. Then on top of that, she's wearing a PET, an extruded polyethylene surgical gown. You can just see that she has got a blue top on there, and that is double layer polycotton with a barrier membrane in between. And then the pièce de résistance here, we have a level 3 mask, and that's multiple layers of various plastic tufting that are getting right down to 2 microns, which effectively is small enough to minimize transfer of viruses as well. That is pretty much de rigueur for dirty surgery, let alone COVID. And the whole idea of this is to minimize fluid spread. So hopefully you're getting a flavor here for how important it is to minimize that potential spread. And I'm hoping I might get slide 15 if I'm really lucky. Taking its time. Oh, there we go. Just going back to an autoclave. I thought I'd put one of these in. My apologies. This should actually have been earlier. This is just to show you something about waste. Now, I think one of my audience here, Alba, I believe it is, I saw earlier on, Alba was saying she knows all about hospital waste. Fantastic, Alba. I am utterly delighted. You're right. There's lots of waste. And this is the stuff that causes it. This is a plastic-backed paper backing, and then we have a blue-tinted polyethylene that is bonded. And this is what we put surgical instruments and surgical materials into to allow them to go into this autoclave. And you can see there, oh my goodness, look at that. There's a big plastic O-ring round there to maintain pressure. The front of this big door, by the way, looks like the front of a bank vault, because inside the autoclave, we have temperature. You can see it up there. We have pressure. So you're using heat plus pressure. But all of this stuff, the plastic and the plastic treated paper, is thrown away. It's on the floor of the operating theatre. And you might find it absolutely amazing that for what I would consider to be a medium grade operation in terms of amount of drapes, in terms of amount of instruments and materials used, a hysterectomy, removal of the womb. On average, after surgery, the discarded single-use plastics weigh 26 pounds once the theatre is cleared. So that's roughly call it 12.5 kilograms of single-use plastic waste from one single procedure. So why do we do that? We do it to minimize the complications of sepsis by maintaining an aseptic technique. Here's something else for you. Now that looks like a very, very nice syringe indeed, and indeed it is. It's a lovely syringe. It's a 20 ml glass, beautiful German glass. For those of you from Germany, you guys make the best glass syringes in the world. They are made to beautifully fine tolerances. They're not only fluid safe, they are gas safe. So they'll actually push gas through if you need it to. There we've got a metal housing for a safety hypodermic needle, and that stays in very securely. And you can use this as many times as you like, provided it is cleaned and it is sterilized. And that was actually my grandfather's. He also was a doctor. So beautiful piece of machinery, but costing. The costs of high quality glass blowing, and more importantly, very, very careful grinding of glass. You have to grind these almost to the same tolerances as a very fine pair of spectacles, and that's expensive. Hence why German companies such as Zeiss are so good, because they've had so much experience of it. But would all of you be happy to go to your general practitioner or in hospital and have a glass syringe used to inject you? No, I would suggest you would go, no way, keep that away from me. How can you prove it's sterile? I don't want anything that's dirty. So you decide you'd rather have one of those. Great. It's a plastic syringe, 20 mils as well, same size, plastic plunger, side elastic end piece, nicely shaped tip to fit into a hypodermic needle. Fantastic. Why would you use that in preference to the glass? It's not any more efficient, it's not any better, but it's perceived that it's single use and it's cheap. But the perception is that it is safe, and medicine is all about being safe. Use that, you won't get infected. There was a very good example in the USA where a dentist had used the same syringe multiple times to draw up a fluid that he was using. That fluid became infected with hepatitis C, and 22 people got hepatitis C, which has the potential of being a lifelong or serious disease. And there have been many other similar instances. So although it's perfectly safe, and studies have shown that provided that this syringe is suitably cleaned and sterilized, it can be safely used half a dozen times, 24 times, provided there's no degradation of the seal and no degradation of the link with the hypodermic needle, it's safe to use. But they aren't. And the reason for that is driven by a medical legal consideration, the possibility of infection. And that possibility has actually become so overt that there's a number of companies, but this particular company, Lifesaver, has produced a syringe that you can see. That's what a Lifesaver syringe starts off looking like. But once you have put a fluid load through it, it's coated with a chemical substance that changes color. So a Lifesaver syringe turns red, and it's indelible. You can't get rid of it. So if you were in a third world country and somebody approached you with a what we call smart syringe like this that's red, you know that's been used on somebody else, and it's potentially dangerous. It's worrying that there are less than scrupulous healthcare individuals out there who would double use them. But we all have to go back to emerging economies. If it costs money that you don't have, and there's something that appears to be safe to reuse, why would you not do so? So, we've had a good look at some very basic stuff in hospitals. And there's another very good thing. I love these. This is a colloidal dressing. Look at it. You can see this wound through here beautifully. You can see if there's any redness around the edge or any pus developing. Clearly there's not. It's right up to the wound edge. It looks beautiful. You don't have to take the wound dressing down to inspect the wound. If you leave that dressing on, this is gas sealed and fluid sealed. You don't have to disrupt the healing wound. You don't have to worry about potentially introducing an infective organism when it's doing very well. So why not make this extruded colloidal dressing that goes on beautifully from a backing plate? It would be foolish to use anything else. A bandage isn't see-through. It's not as comfortable. It's not as flexible. It's not as stretchable. It's not as moldable. This is the best material for the job, but it's still, once it's been used, goes into hospital waste, goes into the waterways, goes into our oceans, and just like other plastics, breaks down into microorganic plastic. Let's see where we're at on slide 19. Oh, do come along. I'm sorry, I'm having trouble with these. Probably help if I went on to slide 20. And this is to show you hospital draping. Remember I was talking about single-use plastics. Let's ignore the two operators here. Let's look at the plastic booties that are put on to minimize the possibility of infection from dirty toenails and dirty feet. We've then got elastane tights to try and minimize the likelihood of deep venous thromboses. We have our sandwich membrane drape, and then beautifully, we can actually have a drape with a hole on it, with a dressing there that's essentially surgical, and the only bit of skin that we have to break down is making our incision there, and we don't get any cross transfer of any leftover bacteria that have been left on the skin of the patient even after prior to operative cleansing. And all of those drapes go into the bin. Oh, it really doesn't want to change slide, does it? Come along, slide. There we go. So let's get on to some more interesting things. We know about syringes. I've talked about blood bags. I've talked about giving sets. Here's a catheter. Now, let's not be too delicate about it. This is a catheter that we put into a bladder. It's introduced via the urethra and goes up into the bladder. And you can see that that tube there, which is clear to allow us to see what's going on, that tube will be full of yellow fluid, urine. This syringe, however, has been filled with sterile water, and that's been introduced into a second concentric layer in the catheter, and it blows up that balloon. And that balloon's really important. It's there to form a plug to stop this catheter, which has got drainage holes up here, dropping out of your bladder, because it's a bit uncomfortable getting a catheter put in, and if you had one that kept falling out, you'd probably complain. But if you can put one in and it stays nicely positioned in the bladder, it's for comfort. It minimizes patient distress. It helps us treat them better. That's made of plastic. Let's see what else we get. Oh, do come along. I'm sorry, this is seeming to have a bit of a trouble swapping over. I've got some lovely slides still to show you. There we are. Now, that is an endoscope. This is something that we introduce through your mouth, down your gullet, to have a good look around and see what's going on in the stomach, up to the top of the small bowel. We do the same going through the anus, in which case we call it a colonoscope. They're very similar, but effectively this is a flexible fiber optic cable made up of multiple plastic fibers. And look at it, it's beautifully wrapped in a plastic outer coating so that it doesn't allow transmission of fluid and it's easy to sterilize. We've got a plastic handle, we've got some metal there, we've got plastic stitches, and we've got plastic lights at the end of it. And again, there's little lenses in those, all made of plastic. So what that allows me to do is that allows me to look down your throat, look at your stomach. I can identify whether you've got gastroesophageal disease, gastric cancer. It'll let me look at your duodenum. It will let me precisely identify where your disease process is. It will allow me to know what distance. These are usually actually have markers on them, and they show you how many centimeters they are. So we could say there is a problem 17 centimeters from the teeth in the upper esophagus. We know precisely where we're going. We can plan our surgery better. Plastic's great. Come on, slide. Oh, it doesn't like doing this, but we'll soldier on, see what we can manage. Don't have too many more to go. There we are. Now that, for those of you that don't know, that's an inflatable plastic splint. Effectively, it is like the inside of a lilo. It's like an airbed. You pump it up with air. At that level, it's got a one-way valve. It's got a zip on it to make it easy to put on, and it provides support. It allows us to support a limb. More so than just that, this is lightweight. You can roll it up. You can take it in a backpack. That makes it convenient for paramedics for immediate on-site care. You can only take as much equipment as you can carry. So anything that is as effective as this, because you can put it up to high pressure, they are very, very good. This is the default choice. This is an excellent thing. It's a much better splint than 2 branches and some old-fashioned linen bandages. Why wouldn't you carry it? It's made of plastic, it's cheap, and you can throw it away. Now, for those of you who don't know, this is an artificial finger joint. Think of the joints in your index finger, not the knuckle where it goes to the base of the finger, but the ones in between. There's 2 of them. There's one nearer the knuckle, there's one near the tip of the finger. That's one way of doing it. You can put in coated metals that then has metal on metal and tends to produce microscopic amounts of metal dust that can be irritable. This is actually a hinged silastic joint. This is another plastic. And you make a receptor for the spigots and the 2 bones alongside. And then that gives you a very useful joint that's lightweight, as hypoallergenic as we can make it. And that provides a very, very good joint that doesn't have to take a huge amount of dense loading. These are widely used in small joint surgery as opposed to metal and ceramics that we tend to use for major joints such as hips, knees, etc. But we can go further than that, a lot further. I have to take 2 bites of the cherry here every time by the looks of it. Sorry for the slight delay. Maybe I'm overloading it with information and knowledge. I'm hoping that we might actually get that next slide in a little while. That next slide, if I can get it. Oh, please give me the slide because it's a nice one. No, it just seems to have stuck for the moment. We'll come back to it. What the next slide was supposed to actually show you was a 3D printing. 3D printing, which, as I'm sure all of you will remember, essentially relies on plastic at its base. What we can get from that, there we are, is a prosthetic hand. This is manufactured by a company called RoboHand. And if you look at this, this is a 3D printed hand with fine titanium wires that actuate. And look at that degree of control. This is a I love my RoboHand. If you made that out of metal, even with the lightest magnesium titanium, this would weigh 5 times as much. And that gives you an imbalance. It's like a fiddler crab on one of the David Attenborough programs with one small claw on one side and one large claw on the other side. It imbalances the individual. And when you're relearning use of a limb, imbalance is one of the most difficult things to overcome. And as you can see, this is a young teenager, age 12 in fact. And the reason for using the RoboHand here is the lighter weight makes it much easier for the younger individual with less bone and muscle mass to adjust to their prosthetic. And the sooner they adjust and can use a prosthetic well, the better quality of life they have, and the easier they find to move on to further more dynamic or biomechanical prostheses. So there is a huge use of plastic. Impossible to produce a similar item of similar weight from any other material. It's invaluable in developing prostheses. Oh, do we get the next slide? Please, Lord, give us the next slide. There we go. Now we're getting into some more complicated medicine here. It's not complicated per se, but let's just have a look at this poor guy. This is a gentleman who is undergoing kidney dialysis. He is in end-stage renal failure. This is a dialysis machine. And I think you would agree we've got rather a lot of plastic going on here. There's tubes going everywhere. We've got these going in and out of his arteriovenous shunt. And these are then going through various filters, and then it's going through his principal HEPA filter. Now, these in the old dialysis machines that were first invented in the 1950s actually used cellulose, which is a breakdown from plant material. Of course, it had its downsides, its pore size wasn't ideal for filtering out some of the toxins within the blood. So now that is basically made by polyether sulfone. And polyether sulfone is, yeah, you've guessed it, a hydrocarbon-based plastic that effectively looks like a microscopic tea bag. And it keeps the good stuff and gets rid of the toxic materials, primarily urea, which contributes to the sickness and the yellow tinge that you see in the eyes of individuals who are uremic, which is what we call individuals who have excess urea from ineffective breakdown of toxic materials in their kidneys. But we need a lot of plastic. Maybe I might get slide 27. Yeah. Now you'll all recognize this. You've seen this on ER, you've seen this in lots of TV dramas. Hopefully you've never seen these up close and personal. We'll ignore the plastic there on the stethoscope, a basic piece of equipment for a doctor. These are defibrillator paddles. And you've seen them used on TV. Admittedly, what happens with the patients can either be less dramatic than what really happens or more dramatic than what really happens. But the reason for the plastics here are, again, they're not frangible. You can drop these and they're not likely to break. The more important thing is, though, if we're putting 200 joules through these, you don't want to be touching them. And plastic is a marvelous insulator. So for just about any electrical item of medical equipment, plastic is an ideal material because it can be molded to complex shapes. It's not fragile and it's hugely insulating. Problem with these is these are quite dense plastic because there's quite a bit of force goes through a paddle when you're leaning on them, and with the patient's reaction, they need to be strong. And this is the kind of dense plastic that tends to act as the rock that grinds down other plastics into the microorganic plastics that we were talking about. So we must be nearly there. Oh yeah, this one is just to give you an insight into what it looks like when you're doing open heart surgery. This is a cardiopulmonary bypass machine. You could theoretically make all these plastic connections with woven stainless steel and natural rubber hoses, which the boys amongst you and some of the girls who are keen on cars will recognize from motor vehicles and motorcycles. The problem with those is they're not transparent. They are very difficult to clean and sterilize properly, and they are massively expensive. They do not have the ability to stand up to the rigors of day-to-day hospital use. They do not have the flexibility. They do not have the ease of fixing. And more importantly, you can even coat the plastics within certain of these components. And this whole machine effectively has complex membranes. And you can coat those with a micro coating of plastic on the plastic that minimizes blood clotting, which of course is hugely important. If we can prevent pulmonary or brain emboli, of course that's a good thing. So plastic again is the best material for the job. So I hope with that history and taking you through various items of plastic that are used on a day-to-day basis, you can see that in day-to-day healthcare around the world, plastic it's essentially impossible to replace. But there's a problem with that. An average hospital's waste consists of 25 to 30% of single-use plastics. That's not only the items we've mentioned above that you've seen. Think of the canteen plates, think of the disposable plastic cutlery, the disposable cups that are used to feed the patients and which are used to minimize the potential of infection. Rhinoviruses, gastrointestinal viruses. If we can use sterile disposable, we minimize hospital-based infection. So where are we going to have a problem? What can we do about it going forward? The basic dichotomy in healthcare is do no harm, and worldwide patients expect doctors and healthcare workers to bring about the most positive outcome. Get them better. That's essentially they want. So that supports an excellent argument for single-use plastics. How do we minimize cross-contamination and cross-infection within a hospital or indeed in a general practice and community-based health setting? We use single-use plastics because they're thrown away. They are thrown away and they minimize immediate issues of cross-contamination and infection. But that's ignoring the global problem. We can introduce smart syringes, we can minimize those kind of issues, but the syringes get thrown away after one use. Not because they're not any good anymore, but because public perception is that if they're not thrown away, they're a risk of infection. The costs of re-sterilization and reuse of equipment, that is all a cost that's added on everywhere in the world. Really, the UK is almost unique in that we have an NHS where anyone here doesn't have to worry about the cost of the consumables in their treatment. If we're being treated in the States, just as an example, every single syringe used, every dressing used, you would be paying for it. And it is a consumable cost that is added on to healthcare. It's perceived that these consumables need to be used, but there's an excellent argument that in some cases, better sterilization techniques, better cleansing techniques would allow reuse or repurpose. So we need to have a sea change in the world population view of plastics. Plastics is an epidemic for future generations. It is something that is going to get worse. And I probably am not going to live long enough to actually see all the effects of microorganic plastics on the human race. But we can see where we're heading, and I know some of the other experts that you're going to see will deal with this in more detail for you. But I'd like you to think as a final thought that governments worldwide cannot afford to pay for safe disposal of plastic, particularly emerging economies. We need to have governmental enforcement of a concept that exists but is not widespread yet, which is called extended producer responsibility and take back. And basically it's directed at big business. It essentially says, you're producing these plastic items, we're footing the bill for their disposal. We cannot afford to do so financially and due to the environmental impacts. If you produce those items, you, the company producing them, is going to have to pay for their safe disposal. Now, as my very final thought, the global plastic market is worth 1.2 trillion US dollars annually. That's 2/3 of President Biden's stimulus package for the whole of the US post-COVID. So there's a major financial inducement for producers to start investing in appropriate and ethical disposable and recycling. Recycling that is hugely underutilized. And what we could see is all these plant-based bottles from Coca-Cola being recycled and being reused. Plastic's great. You can melt it down. You can essentially sterilize it during that process, and it almost seamlessly goes back into a re-injection cycle to produce new plastic with virtually zero degradation. As the thought, the US, where Coca-Cola is based, only recycles 8.4% of its reusable plastics, its recyclable plastics, its single-use plastics. Europe does much better. Europe manages 42%, and for that we should be giving ourselves a pat on the back, but there's still a long way to go. But interestingly, Norway recycles 97% of its reusable plastic bottles. The reason for that is there's a deposit on those bottles, and people get money back for reutilizing those. So perhaps we need to look at the demographic psychology of recycling, its education, its minimization of use of plastics on a one-time basis if we possibly can. But above all, we need to recycle, and to recycle effectively. If we do, all of these pieces of equipment that I've shown you can continue to be used for convenience, for sterility, and for your long-term health. If we don't, all of these materials produced by medicine and healthcare are going to constitute a 30% burden to our plastic disposables worldwide within the next 50 years. And that's going to be intolerable for future generations. Ladies and gentlemen, thank you for your attention. I hope that was educational and gave you food for thought. And as perhaps you've been able to see, for me, there is actually a very balanced argument for and against plastics. There's tremendous usage. There are tremendous risks for them over the longer term. Now, if you don't mind, my slide number 29, if it's not too late, is actually saying you can have a question and answer session if you'd like. I'm not sure what the easiest way would be for the controllers. Can I pass that to the controllers to let them give you all some idea? Thank you. If anyone's got a question, please, feel free to come online and unmute your mics and ask me, and I'll do my best to answer. Ooh, you can't do that. Aha, I see you've got no microphones. My apologies, guys. And my answer to Judge Dorota is no, I can't imagine my work without plastic. We need to get on top of recycling and repurposing. Kitty, I see you've got a question. Plastic should be banned in relation to medicine and health. The honest answer is I don't think it can be. It is too useful a material, and we don't really have any substitutes. There may be new developments that come along, and certainly, forgive me, I'm getting feedback through my headphones. We're probably going to see better and better bioplastics from plant-based sources. But I think that a better route, certainly in my opinion, is increasing recycling of plastics to the level that Norway's achieved with their plastic bottles, and then utilizing that to remanufacture or repurpose the items that are required. Being cynical about it, there are hugely influential companies that are producing a lot of these things, and they don't want to have to go away from their plastic golden goose. If they are then able to repurpose, they are still going to be market leaders, but we're going to effectively end up with a cyclical economy that's going to use recycle, repurpose plastic, and then we shouldn't add an increased plastic load. And over time, we should be able to minimize plastic waste, microorganisms, and minimize use of landfill, which is very bad because you get very, very slow breakdown and huge amount of methane produced. Oh, Harry, best way to make the transition from single-use plastic without damaging world economies? Great question. Honestly, I think what we're going to have to do is to effectively have government basically doing the extended producer responsibility and take back. These are multi-billion-pound companies that we're talking about. They have the wherewithal to actually invest and enlarge the capability of plastic composting and initiating educational initiatives, which encourages reuse of plastic. I think that's where it has to come from. I don't see why government should have to pay for it. It is a downside of a product, and a lot of these plastics that they produce are actually remarkably cheap. So per item that they produce, a small amount of money from each item, incrementally with compound interest, gives finance. It's estimated, incidentally, that the cyclical economy I'm talking about would cost $600 billion. That's only 1/3 of President Biden's COVID stimulus package, and that is initiating everything that we need to go forward. Oh, Rebecca, how much time to change and be conscious about plastics? That's a very good question, and the answer is simple. The longer we delay and we don't educate, as we're attempting to do here and now tonight through this presentation, the longer that's delayed, the slower it will be. I think that your generation is very open to it, and I'm hopeful that within the next 10 to 20 years, we'll have a major sea change. Ooh, materials to replace plastic in medicine. That's a very good question. Carbon fiber is a possibility. Graphene, because of its strength and moldability, is certainly a possibility. Some new metal weave polymers, but those all come with cost. I personally would bet on graphene for strength and capability, but we've got a long way to go in the biotechnology department to get us there. Okay, reuse of plastic, a good idea. Absolutely, Ellie Mae. It produces a lot of carbon. Existing landfill sites of carbon sink. Yeah, you could say that. If it's there already, I agree with that. You could also use mines that are no longer functional, but I would hit back at you and say, absolutely, there's lots of carbon released with it, but how about we look at increasing our green footprint, and how about we look at replanting of vegetation and trees who can take carbon dioxide and turn that into energy and oxygen. You know, education is not just about the plastics, it's about the bigger ecosystem. So I think we have to do that. Isabel, plastics used aren't that essential. Yeah, those hypodermic syringes that I was talking about, the little plastic end cap that you put onto the end of the syringe, we don't really need those. You can have a nice little metal one, and then you have an all metal syringe. And effectively, that can go into a sharps box, and that is high-grade surgical steel that can just be melted down, refashioned straight away. It's not that expensive to actually do those fixings. It's a little more expensive than plastic, but it's become trendy to do it with plastic because you can make nice colours, and the colours just tell you what bore the needle is. That's what the colours are for. Other countries should adopt the same method, same method of a deposit on certain plastics like Norway. I think it's great. If you get 97% return of an item that's a major polluter just by using a deposit which the individual is paying for and the cost price of the item, why wouldn't you? It's really stupid not to. I think Norway is very smart. They've got lots of money, they've invested well, they look after their population. Sure, a coffee's expensive there, but there's great fishing. I love Norway. I think they're smart. Reduce plastics by using hybrids of materials. Now, Alistair, that is getting outside my knowledge comfort zone. I suspect hybrids, unquestionably. I don't have enough direct biochemical and biomedical engineering knowledge to tell you what the best hybrids is, but there's much cleverer people than me that I'm sure would say hybrids would be useful. Okay, efforts to reach less economically developed countries. Well, that all comes from the whole idea of the extended producer responsibility, doesn't it? Look at the huge amount of plastic waste that's going into the rivers in Asia, Africa. I mean, we're looking at undeveloped or developing economies there, and they've got a huge amount of plastic. So they're using a lot of plastic. They're not using just, raffia baskets or banana leaves to carry things. So, yeah, I think an end user extended producer responsibility and take back is important. And Alba, the final question there. Oh, I'm sorry. Yeah. Is it going to be resolved in the next 30 years, or is it going to upend in human existence? Whoa, you're just asking one guy here. I would suggest to you that the more the doomsday clock ticks down, the more big and clever brains get to work on it. I think it's probably going to get worse before it gets better, as it always does. But I think the responsibility is with your generation to influence and refuse to utilize excessive plastics. And if big companies can't sell the product in the plastics, they're going to have to change their methodology. I also think there's going to be a big growth in biodegradable plant-based plastics that aren't as environmentally harmful. And finally, yeah, I think sanctions is certainly something that we're going to have to think about. There's a lot of other issues that China might or might not be on the end of sanctions for. It's a complex geopolitical question, whether you're looking at mistreatment of the Uyghurs, whether you're looking at plastics, whether you're looking at buying up large amounts of real estate with a long-term view to influencing the politics in other countries. China has a different way of doing world business to many others. But if it's affecting all of us worldwide, yes, I believe we should start thinking about it. But remember, for politicians, most of them, particularly in the developed world, are old white guys like me. And most of them aren't switched onto environmental issues, so it's not high on their agenda. But the next generation of politicians that are coming through it will have to be high on their agenda. Marta, the answer is if we knew how to neutralize microplastics in the oceans, we'd have done it by now. But the problem is they are so insidious throughout the oceans of the world, and they are so small. Really getting those together and being able to trap them is an extremely difficult issue. It's going to be much better. We're essentially going to have to wait. We're going to have to wait on ultraviolet radiation, oxygen, sunlight to drive that. But if we don't put any more in, the world is very good at healing itself, and chemical processes will ultimately break that down. The more pressing issue at the moment is the amount of microorganisms within the food chain. And I think that's all the questions answered. Thank you all so much for your keen attention, and I'm sorry I've run 5 minutes over time.